This was about a 50-year-old working telephone repairman who had had a terrible burn about a year prior and developed a blood clot in his lower leg on the left side. And he subsequently developed sores in his leg which wouldn't heal with treatment. We looked at him and determined that he needed a venogram, which we did, and it showed that he had a blood clot up to his knee, but not higher. And this did not explain his symptoms. So we decided to inject contrast in his groin and with him standing, and when the contrast descended in his leg, it showed leaky valves. With that problem, we said that we needed to do something that would correct his swelling problem as well as try to heal the ulcer, and determined that it would be well to get rid of the veins that were leaking in his leg. So we did an interruption of perforator veins in his leg, and then 3 days later took him to the operating room for an operation to explore the veins up near the groin called the femoral veins. When we explored those veins, we found the leaky valves as we had seen on the preoperative studies. And there was a history by another physician, Robert Linton, many years ago, that indicated that it was a good idea to ligate the femoral vein if it had leaky valves. And with that in mind, partially in mind, and also with in mind the thought that we could take a look at it and see if we could do anything about fixing the valve. So we explored the vein, found the vein there, decided to open the vein, which we did, and found, instead of a diseased vein, found a beautiful vein with totally normal tissues throughout. And the only thing that was wrong was when we opened the vein, we could see that the valves had two cusps, and the cusps of the valve were folded and too long. They were inappropriate, so that the blood that was higher than that valve would just leak through the valve. But seeing that, it seemed like it looked like if we just brought those valves up to the sides of the wall and shortened the valve, that it might help. So we did that with a series of interrupted sutures of fine material. Closed the vein, and when we closed it, the valve worked perfectly. And as a matter of fact, it was so good that you couldn't force blood back through the valve. Well, with that result, we decided not to tie off the vein and ligate it, but to let it go. So we put him on anticoagulants and watched him very carefully, because we were afraid that all of the fear that had been that people like that might get a blood clot, which would go to their lung and cause serious trouble. He didn't have that problem, and the next day he said, "Thanks, Doc, for fixing my leg." I said, "Well, you're welcome. Does it feel better?" And he said, "Well, absolutely, no, it's well." You know, by this time in the development of vascular surgery, we had been working with arteries and using anticoagulants for a long time, and so the idea of using them in the veins was perfectly natural. So I don't think it was that exploratory, and because of the developments that led up to it. So one doesn't do something radically different without any idea that it might work. It seemed like it was appropriate. In the post-thrombotic syndrome, those veins had previous blood clotting and inflammation, and they tend to be deformed valves, valves with strictures around them and scarring, and it's a totally different type of problem, where usually the valve itself is not repairable, and one would have to do some kind of different operation. So in the post-thrombotic syndrome, we began to figure out that, well, if this valve doesn't work, maybe the valve in the vein next to it, we could just switch the vein over to that valve. And so that led to an operation called transposition, which would just transpose one draining channel into another valve segment. We learned that we could clean out the vein and clean out the bad tissue in the vein and keep the patient on anticoagulants and that the vein would not thrombose and would not become a blood clot problem. And so we learned that the vein does tolerate intravascular, inside the vein type of surgery, as long as you have good inflow and good outflow from the vein. Using the principles that we had learned to operate in the arteries, we applied those to the veins, and they worked out for a lot of challenging different situations.